So I am very sure I would like to simplify this topic by understanding there are two basic parameters for tenosynovitis of the hand and wrist. One, we try to find out whether the cause is infective or the cause is inflammatory. And infective, the commonest causes are bacterial. I have not surprised in my practice that Cox is also one of the very common cause as a infective tenosynovitis. Let us now understand each and let us now just a minute. Yeah. When we consider a lab diagnosis for such cases, the infective causes are we have to find out whether the ESR or CRP is high, and many times the inflammatory tenosynovitis are referred to us by a rheumatologist or a physician, and we need to consider this battery of tests. When should we consider a ultrasound or a MRI in when we see such cases? When try to find out clinically whether the pathology is inside the joint or outside the joint. We should consider ultrasonography when we are considering a localized disease. If the relatively non-tender area, sometimes skin condition or a ulcer or a burst abscess and too much tenderness along the digit, usually we should consider a scan. And if you are not suspecting any skip lesion or the disease is more localized, we should consider ultrasonography. I am going to discuss 4 to 5 cases. Like this case, the patient had a post-traumatic injury at the thumb tip, probably while cutting the vegetable. And if we see, there are signs of phyllon also. So there is a nail bed infection. And this redness along the thinner aspect suggestive of flexor pollicis longus, as well as the dorsal aspect is suggestive of extensor pollicis longus tenosynovitis. These patients usually need a thorough debridement, and once you debride them and take a culture, and then these patients usually heal well in by primary intention. And these cases have to be done under digital under the local regional anesthesia and tourniquet. Usually wound healing is never an issue, and they usually have excellent result. Apart from infection, now let us consider one more case where this patient had a diffuse lobular swelling along the full length of middle finger. Functionally she was better, but there was localized tenderness and there was no other history. So in this case, I would like, we had done a MRI because the swelling was right from the FDP insertion to the palm. And if we see a MRI, the black shadow is a suggestive of tendon and the white shadow is suggestive of extensive, hyper intense lesion. So when we did a exploration, we could see a extensive flexor tenosynovectomy. Usually lesions, we do a culture as well as we a biopsy. This patient was diagnosed to have sarcoidosis, and the rheumatologist had started a AKT for that treatment. Let us take one more example of a 58-year-old who had a liver cirrhosis due to primary portal hypertension and no history of trauma, and he had significant tenderness along the dorsal aspect of the wrist. These were the blood parameters. When we consider his MRI, there was intracapsular hyperintense lesion in the wrist joint. There was some white shadows on the dorsum of the wrist, and then we decided exploration of the wrist from the dorsal. I would like to show you how a pathological tenosynovium sounds when we cut. Usually a normal tenosynovium will not sound like this. And apart from that, we had to consider an intracapsular synovectomy also in this lesion. And as the patient was 58-year-old, already started developing CRPS symptom, we had to consider a neurectomy of this patient because that was the reason to control the pain. And after that, the CRPS was certainly improved. If you see the same patient, uh, if you see this patient at follow-up, and all wounds were healed by primary intention, and histopathological diagnosis was non-specific tenosynovitis, and he definitely have had a reasonable range of movement. Sometimes we see a iatrogenic infection. I have seen that we may consider de Quervain's disease or a trigger finger release is a small surgery. If the proper aseptic precautions are not followed during these surgeries, they can have a significant infection. And here I am doing a first extensor compartment release completely, and there was infected tenosynovium. the culture came up Staphylococcus aureus, and usually if your debridement is proper, they all heal by primary intention. In this video, I am doing neurolysis of the superficial radial nerve, and these patients usually they heal by primary intention with good range of movement. Her CRPS recovered the moment we considered the neurolysis of the superficial nerve and we controlled the infection. Now, I would like to take one more case, like this was a case for a post-mosquito bite injury. Whenever we are discussing tenosynovitis, we must discuss Canavel signs. What are the four Canavel signs? One is diffuse, uniform, swollen finger. There is a pain along the full length of the flexor tendon. Many times the passive extension of that particular finger is painful, and then you see a redness. So for that patient, we had to now, this video will suggest that we have taken a small incision at the distal sheath, and we have taken an incision on the proximal sheath as well. And now I am going to drain the pus from proximal to distal. There was not significant pus, but then we opened this case, this finger very early in time, and that's why we could manage to get a good result. But now here, such cases, usually I pass a infant feeding tube along the sheath, and this is helpful for putting a diluted betadine lotion to control infection for 24 hours. And this usually heal by well in secondary intention. This is the case. Young lady had come with a no history of trauma, but abscess formation around the dorsum of the wrist. And if you see the MRI picture, the X-ray was normal, but the MRI picture showed a significant collection, and that was a proper pus formation. And it turned out to be tuberculous abscess, and this patient had a reasonably good functional outcome. Though she had a restricted flexion, this follow-up is at least a 1.5 month follow. Now she is much better with anti-tuberculous treatment. So many times sometimes we see a carpal tunnel syndrome very commonly, but please try to examine such patient whether they have a reduced grip strength. Whenever we see a reduced grip strength in a patients of carpal tunnel, usually we suspect a hypertrophied flexor tenosynovium. So after a nerve decompression, we must consider a proper tenosynovectomy of this particular in cases of carpal tunnel. So that it can be done by mini open carpal tunnel surgery, but usually when the significant grip strength is less, I try to consider a complete tenosynovectomy for this. And to my surprise, when I sent this for biopsy, it turned out to be rheumatoid etiology. Pre-op diagnosis, it was not there. The take-home message is tenosynovitis of the hand and wrist you will find the etiology. Try to find out. Surgery is for not only synovial biopsy, but sometimes the total synovectomy definitely relieves the pain and improves the function. And when to consider a USG and MRI that I have diagnosed, when we are considering a skip lesion, then please consider MRI. And surgery has to be done under regional anesthesia and tourniquet. This cannot be done under local anesthesia, but yes, Wallant can be described, but I would prefer a regional anesthesia. Thank you very much.